Hello, 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 everyone, and welcome to this lecture on hypertension. All right, so let's dive right in. Hypertension is known by its other name, which is just high blood pressure. So, hypertension is high blood pressure. It is one of the most important factors in the development of cardiovascular disease in the fact that it is modifiable, which means that it's something we can do something about. So as the blood pressure increases for patients, so does the incidence of heart attacks, heart failure, strokes, kidney disease, including failure, and impaired vision from retinopathy. Almost half of the adults in the United States are affected by hypertension. So you can see that this is a big deal. It takes a lot of resources to take care of patients, and they don't do as well, right? It is up to a quarter of the deaths are due to heart disease associated with hypertension. So the edict is clear, right? We have to do something about hypertension. Looking at health equity, it's pretty well known that African Americans do have the highest prevalence of hypertension, and they actually do tend to have more treatment-resistant hypertension. Males have more hypertension than females. They develop it younger. So, for example, I've never been diagnosed with hypertension. However, my husband's been on medication for many years. Hispanics also suffer from hypertension, but they're less likely to get treatment for their hypertension and have lower rates of awareness of treatment. So again, so we look at this in total as population issues. Again, differences between men and women, differences in the different ethnicities. You can see that some groups have poorer outcomes because it's harder to keep control of their blood pressure. All right, so let's talk about how we get our blood pressure. So blood pressure is the force that's exerted by the blood against the blood vessels, and we check the arteries, right? So we're checking the brachial artery, you're getting those blood pressures. We rely on the ability of the heart to augment its cardiac output and maintain our blood pressure even in activity or in rest. All right, so cardiac output is basically the stroke volume times the heart rate. And there's some factors that influence blood pressure which you should be aware of, and this is from the Lewis's Medical Surgical 11th edition. So things that affect the blood pressure, you have our sympathetic nervous system, our alpha and beta receptors, vasoconstrictors that we naturally make, our kidney system, our heart. So lots of different things go into making sure that we can maintain our blood pressure, whether we're resting, whether we're in activity. All right, so autonomic control of the blood pressure is accomplished by the sympathetic nervous system. This should hopefully be a review for everyone, but sympathetic nervous system basically has a lot to do with our contractility, along with rate as well as force of contraction. So that fight or flight response can get that heart moving very quickly and also get the blood pressure up as well. And the other end of things is the parasympathetic nervous system, which is our rest and digest, right? Decreases the heart rate. This is our vagal stimulation and decreases our cardiac output and our blood pressure. It's very important to know about the nervous system receptors for our blood pressure because a lot of our medications that we have actually work on the sympathetic nervous system. So our alpha blockers, beta blockers, some of our vasodilators. So remember, the sympathetic nervous system is activated during stress, pain, exercise, all of this to increase our cardiac output and our blood pressure in response to the need for more oxygen. And sometimes if we have these sort of transient changes in our blood pressure, that can lead to the sympathetic nervous system stimulation to give us peripheral vasoconstriction to increase our venous return. And when this system is impaired, that can lead to dizziness or syncope, right? So our response to these changes in position and our inability to adapt during those times of stress and exercise, such, right, that would lead to dizziness and syncope. Endothelium, which is the lining of the inside of our blood vessels, is very important because it gives us some of our actors for vasodilation and vasoconstriction. And to understand that when people have smoking and diabetes, this is a risk factor for cardiovascular disease because of what it does to the endothelial function, right? It alters it. The kidneys have a lot to do about blood pressure, right? They control our sodium levels, and that also, the kidneys also control our volume, blood volume. We have the RAS system. So again, that's a whole other lecture on what the renal system does, but understand what it does as far as hypertension. And this is why a lot of our patients with kidney disease have hypertension issues. Heart also has the secretion of natriuretic peptides. So if you recall, the BNP is something that we look at to tell us if we're in heart failure. Basically, they oppose the action of antidiuretic hormone and aldosterone. So this basically makes the body want to excrete the sodium in the urine or get diuresis, which basically would result in a decreased blood pressure and a decreased blood volume. The endocrine system, again, this is just a review about the fight or flight, epinephrine, norepinephrine, which at times of need can, within seconds, give us more cardiac output and increase our blood pressure. Aldosterone, which tells the kidneys to hold on to more sodium, and water does follow salt in this case. And then antidiuretic hormone, which tells the body also to hold on to the fluid, right? Don't pee it out because we want to keep perfusion. All right, and here's just a little table that's basically how we classify hypertension, and this is for adults, so those over the age of 18. Normal blood pressure, we would want our systolic less than 120 and the diastolic less than 80. Elevated, pre-hypertension they used to call it, 120 to 129, and the diastolic is less than 80. Stage 1 hypertension is 130 to 139, or a diastolic blood pressure in the 80 to 89 range. And then stage 2 hypertension is the systolic greater than or at least 140 or higher, or the diastolic to be 90 or higher. So pay attention to those and or statements. All right, so again, that's classification of hypertension. So let's give a quick little question. So the nurse determines that the patient has stage 2 hypertension when the patient's average blood pressure is what? And it's select all that apply. When you're ready, you can press play, but put yourself on pause while you look at those and decide, is it stage 2 or not? And here is the answer. A, B, C, D, and E are all stage 2 hypertension. Because if you look at the systolic or the diastolic, that's where it is, okay? Now there's a couple different types of hypertension that are out there. Of course, there is primary hypertension, which is called essential hypertension or idiopathic hypertension. This is the one that we don't know what causes it. most of the cases are primary hypertension. Some of the contributing factors are listed here. And basically, the more risk factors you have, the more likely you are to have hypertension. And it also contributes to the progression or the consequences of the disease. All right, so what are some of the risk factors? We have increasing age, use of substances, alcohol, tobacco, diabetes, increased lipids, increased dietary sodium intake, gender, of course, family history, obesity, ethnicity, our sedentary lifestyle. I mean, we even have kids with hypertension now. Socioeconomic status and stress. Now, you can basically look at what all of those do, right? So, blood pressure rises with age. There is a huge correlation between alcohol intake and hypertension. But we do know that some alcohol intake is protective, so we do recommend that males limit their daily alcohol to 2 drinks per day, and ladies, I'm very sorry, it's 1. Diabetes is more common, hypertension is more common in those with diabetes. Think about the viscosity of the blood. Atherosclerosis can occur because of the lipids. Hypertension does tend to run in families. So if your family is full of hypertensive people, you're probably going to get it too. And remember, for gender, more common in men and more likely to happen to them earlier than life. But after the age of 64, then hypertension is more prevalent in the females. And we know that a sedentary lifestyle is dangerous, and people should be exercising, right? We want some moderate exercise. All right, so there's lots of different things, right? So secondary hypertension is a little different. Secondary hypertension is increased blood pressure with a specific cause, right? It's sudden development. This is not something that people would usually have a history of. They don't have a history of hypertension. And there is a table in the 11th edition of the Lewis textbook, which you can look at if you have access to that. And in order to treat secondary hypertension, you have to treat the cause of the hypertension. Right, we already talked about a genetic link, so it tends to run in families. So let's try a question. While performing a blood pressure screening at a health fair, the nurse counsels which person as having the greatest risk for developing hypertension. Go ahead and read through the choices and pause, and we'll see what the answer is. All right, so the answer is the 56-year-old man whose father died at age 62 from a stroke. So history of a close blood relative, like a father or son with hypertension, is associated with the increased risk for developing hypertension. And atherosclerosis is the most common cause of cerebrovascular disease. And hypertension is the major risk factor for cerebral atherosclerosis and stroke. So that is why A is the correct answer. Okay, so as we get down with the patho a little bit more about sodium and water retention, there is a proposed link among salt intake, blood pressure, and changes in the heart. And the reason this is because if somebody has excessive dietary salt intake, it has hypertrophic effects on the left and the right ventricle, potentially. Basically, it tends to affect the renin-angiotensin-aldosterone system, works with some growth factors. I mean, you could get lost in the patho of this, but to understand that water and sodium retention does have a link, not as strong as you would think initially. So 33% of people, 1 in 3 people who get the high sodium diet would develop hypertension. Those who have altered renin-angiotensin-aldosterone system, so the RAS system, they would be more likely to suffer from hypertension as well. Those who have prolonged stress, right? People with insulin resistance, and those with endothelial dysfunction. So let's start talking about some of the clinical manifestations of hypertension. Guys, it's called the silent killer for a reason, all right? It's asymptomatic until there is severe end target organ disease, right? So the person comes in with a stroke, a heart attack, they have angina. So up until that point, they have elevated blood pressure, but really there's not too many signs and symptoms. So target organ disease. What does hypertension do to the organ systems? Right, for the heart, it causes atherosclerosis, left ventricular hypertrophy, can cause heart failure. For brain, it can cause TIAs and strokes. It can cause changes in the autoregulation of the brain, resulting in encephalopathy. You could see that it can cause problems with the peripheral veins as well as the arteries. It can cause aortic aneurysms, aortic dissections, kidney disease, blindness. When you look at hypertrophy of the heart, so on the figures, and this is from the Lewis 11th edition textbook, basically you have a massively enlarged heart. So look at how thick those ventricles are and how little space there is for blood, and compare that with the normal left ventricle that is B. All right, so let's look at how we diagnose blood pressure and how to measure a blood pressure appropriately. All right, in order to get an accurate blood pressure measurement, you want to have your patient seated with their feet flat on the floor. Don't let them cross their legs, nothing like that, okay? We get the blood pressure in both arms. We don't average them. And when we do take the blood pressure, we get that cuff deflated at 2 to 3 millimeters of mercury per second. All right, so you guys should all know how to take a manual blood pressure at this time. Some of the other things that we do to diagnose blood pressure and looking for some end organ damage is make sure that there's no reason that they have hypertension, like a secondary reason. We look at their target organs. So somebody with high blood pressure, we're going to look at their eyes and their heart function and their kidney function, determine what their actual risk is, and we always want to establish baselines before starting therapy. So again, the text does a really good job of breaking down some of the testing, 12-lead EKG, eye exams, all of that. Now, there's something called white coat syndrome that you need to be aware of. And white coat syndrome is one where the person actually has increased blood pressures because of their anxiety of being with the doctor. So anytime you check their blood pressure clinically, it tends to be a lot higher than it would be normally. So basically, if this is something that's happening, then one of the best things we can do is kind of get some blood pressures in their own calmer locations. So we might send them home with a blood pressure monitor and have them record their blood pressures at home. So that way we can sort of see what's going on. Is it white coat syndrome or something else? All right, overall goals of blood pressure treatment are to get that blood pressure in good range, reduce the risk factors that we can, and make sure that we can avoid target organ disease. So make sure that our brains and our kidneys and everything else stays healthy. And the American Heart Association did put this out. I'll let you read it, but this is exactly what we need to do to have good, healthy vessels. Weight reduction is probably one of the best things that we can do. It's got a very significant effect on lowering the blood pressure. So even moderate weight loss. So the textbook is pretty clear. It says that every kilogram of weight loss, the blood pressure will decrease by 1 millimeter of mercury. The DASH eating plan is recommended. So basically, it stresses the fruits and veggies and the low fat milk products, right? Because we do need calcium, nuts and seeds, uh, but it limits the fatty meats and the full fat things, and just basically all the tasty stuff is limited. All right, and we do need to have dietary sodium restrictions. So the salty six are on there. I don't know about you, but I eat the salty six all the time. Oh, they're so delicious. So I would not be a good patient to have hypertension right now. It would be terrible. But also note that there is hidden salt in a lot of other foods and even products that you may not even think of. So we definitely want to teach our patients to take a peek at those things. So read the label of everything. All right, so alcohol intake. Remember, men, 2 drinks a day, women, only one. We want to have moderate activity, 30 minutes at least 5 days a week, right? Goal of 150 minutes per week. I don't know about you, but I'm not getting that myself. So I think I need to increase some of my activity so I can definitely decrease my risks of cardiovascular disease. All right, and along with some of the risks that we just don't need to take, avoiding nicotine, right? Nicotine's a vasoconstrictor, can cause elevated blood pressure, so we can get some really good gains by quitting smoking within the year. And then some other risk factors, the socioeconomic status, some of the psychosocial factors, those who are under frequent stress. This is why those high powered executives in those stressful jobs have heart attacks. As far as drug therapy here, there are guidelines to when we would start treatment and what kind of treatment it is and what their goals are. So just familiarize yourself with this. But understand that as we treat blood pressure, remember what I say, sometimes we can give too much. So we are going to look for over treatment as well. Our drugs that we have to choose from basically do two things. They can decrease the blood volume or decrease the systemic vascular resistance. So, um, drugs that are used in the treatment of hypertension include things like diuretics that promote sodium and water excretion, the adrenergic blocking agents or inhibiting agents. They basically diminish the sympathetic nervous system effects that increase blood pressure. Adrenergic inhibitors include drugs that act centrally on the vasomotor center and peripherally to inhibit norepinephrine and also block the receptors in the blood vessels. Direct vasodilators, those decrease blood pressure by relaxing vascular smooth muscle, so that decreases systemic vascular resistance. Our calcium channel blockers, look, let me move it on down here a little bit. We'll take a look at those ones. You'll be able to see it. Calcium channel blockers increase sodium excretion. We have our ACE inhibitors that prevent the conversion of angiotensin 1 to angiotensin 2. And our ARBs, right? They prevent angiotensin 2 from binding. So ACEs and ARBs. So you have on here a few slides, right? So some of the adrenergic blocking agents would be things like clonidine. So clonidine is a centrally acting medication. So something like clonidine, I was very familiar with it as a young mother because my child was on clonidine for his autism. So it kind of helped him with that. We were not looking to treat blood pressure, right? But we were looking for the side effect of the med, which gave him a little bit more sedation. He needed to be able to slow down a little bit. All right, so something to think about with our medications that if we have a sudden discontinuation of some of these meds, that the person could end up with rebound hypertension, which could lead them to a hypertensive crisis or emergency. They could have tachycardia. These folks, they may have dry mouth. Some of the other agents that we have the alpha blockers like Cardura, Prazosin. A lot of times we take those ones at bedtime because of the orthostatic hypotension. And to be clear, all of these medications that we're giving, all of them can cause orthostatic hypotension. So you always want to have teaching to your patients about how they're moving, right? We want slow position changes to allow time for the vascular system to compensate. Our beta blockers, those would be things like atenolol, bisoprolol, metoprolol. Those are cardioselective. We also have the non-cardioselective things like nadolol, propanolol. So what's the difference? Some are much more safer for our patients with asthmatics. So those would be the ones that are cardioselective, meaning they select the heart, versus non-cardiac selector, because remember there's beta receptors in the lungs as well. So those meds could cause some problems with bronchospasm, especially in those who have asthma. All right, ACE inhibitors, they can cause potassium retention. So we want to make sure that we're teaching our patient not to increase their potassium levels. Other thing about the ACE inhibitors is their aspirin and NSAIDs, they kind of interact and reduce effectiveness. Angiotensin 2, so our ARBs, those are the ones that end in sartan, can take up to 6 weeks to become effective. A lot of times if a person has an ACE inhibitor and they develop that cough, they might have to switch them to an ARB, right? Because it's better for them. Anybody who has kidney disease, we don't use ACEs and ARBs together, right? So then it doesn't leave any mechanism by which angiotensin 1 converts to angiotensin 2 and binds. It takes that out completely. All right, some of the other things that we're always taught about is angioedema as the potential problem with taking an ACE inhibitors, and so any swelling of the face or oral mucosa, that they should immediately notify their healthcare provider because it could end up being life-threatening. Calcium channel blockers. Let's go back up here. Calcium channel blockers. So things like diltiazem, verapamil, nicardipine, nifedipine. Basically, I tend to see like nicardipine and the dihydrophodines. They're used a lot with our patients with that renal disease. Our direct vasodilators. So these are things like clorapam, hydralazine. I see hydralazine a lot more these days than minoxidil. We give nitroprusside. Some of these should be familiar under treatment for cardiogenic shock. All right, so there's also diuretics. I guess we can go back up here for a minute. Diuretics like aldactone, Bumex, hydrochlorothiazide, and all of them have something a little different for you. In the 11th edition of Lewis, if you look around page like 689, this is where all of the meds are. I think 689, maybe even 688. Lots of meds to look at. All right, so we usually start with non-pharmacologic treatment and one first-line drug for just regular hypertension. Stage 2, they go on 2 drugs, and basically we keep adding and taking away and trying to basically work our way into a goal blood pressure. So remember, report all side effects. Different medication can be tried if there are severe or undesirable effects, because we need our patients to take their meds. Some of the common side effects for all antihypertensives. We talked about orthostatic hypotension, decreased libido, dry mouth, frequently voiding, just depending on the type of med that they're giving, right? Now, sometimes if a person has really resistant hypertension, it could be related to the other meds that they're taking. It could be them not actually just measuring their blood pressure appropriately. And sometimes we just have to try and figure out what it is and kind of make sure there isn't a secondary cause going on. All right, and here is how to take a blood pressure. I know I alluded to it earlier, but this is how we take blood pressures. So if we have our patients like up and following us quickly to a room and sitting them down and immediately taking their blood pressure, depending on their level of fitness, this could actually be considered exercise, right? Um, and so that is how you do it. Go ahead and pause and take a look at this. One of the things I think is funny is as nurses, if we have a high blood pressure reading, we tend to go to the other arm to see if it's lower. And we shouldn't do that. We should take the higher reading, right? Make sure you do that. All right. So for orthostatic hypotension, it's very common that you'll have to check for that. This is the procedure to do it. So pause and read that. And you could also look at what the definition is and what would be normal versus abnormal, right? Normally, if you get up and start walking, you would want to have your heart to give you a little bit increased pressure and increased cardiac output. So if that doesn't happen, that's abnormal. As we start to look at out in the community and some of our ambulatory and screening programs, if we are doing blood pressure screenings, which is a great way to give back to the community, by the way, make sure you give the patient their blood pressure reading in writing so that they can follow up with their providers. Long-term management, the person and their loved ones are going to require teaching and the ability to really be involved in their care so that we have more follow through. Is the person actually being adherent to treatment is a big problem. So we do home blood pressure monitoring. We want to teach them how to use their blood pressure cuff. Patients with hypertension should have a cuff at home. And how do we get the person to be more adherent, right? We want to individualize the plans, make sure that they have active participation. Select affordable drugs that they're going to be able to get. Involve their caregivers. Sometimes instead of taking 2 drugs, maybe we can give them a combination drug so that they're only taking 1 pill a day. And again, patient teaching is so very important. Let's try another question. Patient's blood pressure has not yet responded consistently to prescribed drugs for hypertension. The first cause of this lack of responsiveness the nurse should explore is what? The answer, of course, is that the patient is not adhering to the therapy, right? Side effects of antihypertensive drugs are common and they may be so severe or undesirable that the patient doesn't comply. Right, let's talk about our old folks. Increase in incidence with age. The older you get, the more likely you are to have hypertension, the more likely to have white coat syndrome. And you can look at all these age related changes in the cardiovascular system that would affect the blood pressure. And then as we get older, we have difficulty taking a bunch of meds, we have altered absorption of our meds, and as a result of this, for our old folks, most people who have hypertension, we start them with a mild diuretic, usually like a thiazide. And what happens if we don't get blood pressure under control, right? We can get a hypertensive crisis. So hypertensive crisis, there's actually a couple different ones. There's the hypertensive emergency, the hypertensive urgency, and the crisis. So let's talk about the hypertensive emergency, right? this is an emergency. Think, go get an ambulance because it's got target organ damage. It's a huge risk factor for a CVA as well. Heart attack, renal failure, aneurysms. If we do not treat this, up to 80% of people would die within the year. So this is a systolic blood pressure of greater than 180 or diastolic greater than 120. So the difference between that of the emergency and the urgency is whether or not there's evidence of end organ disease. These are the ones that usually have some chronic but stable disorders. The hypertensive crisis, I often will get patients admitted with that because of some of the life choices that they're making, suddenly withdrawing their medications. They have rebound hypertension and a hypertensive crisis. Pardon me, I'm a little tired here recording this. A lot of times my patients are just not that compliant to begin with. They have a lot of socioeconomic status issues. So we might have them in the hospital, get them all settled and send them home with meds, and they just don't take them. They might be using substances, so they come back in. Right, so what does a hypertensive crisis look like? It could be some changes in the brain, like headache, nausea and vomiting, some changes in renal function, so very important to monitor that. They might be having chest pain. If they have an aortic dissection, like our friend who was the actor on Three's Company, John Ritter, that usually happens rather suddenly, and they have like this chest and back pain, and they lose their peripheral pulses. They're very decreased. So under treatment for hypertensive emergency, the person definitely needs to be admitted to the hospital. We give them IV drugs. We do slow titration with frequent monitoring of the blood pressure, because if they're receiving rapid acting antihypertensive medications, we'll need to make sure we're watching them very closely. So these are the people that would be in the intensive care unit. For our patients who are on vasodilators and such, that they should be on bed rest for those medications. So again, hypertensive emergency is hospital treatment. Hypertensive urgency will often have them as an outpatient. We start them on some pretty good meds and usually have them following up within 24 hours to make sure that they are doing well and not going into emergency. All right, couple more questions for you, and then we'll end this here lecture. How about question number 4? Nurse takes blood pressure at a health fair. Nurse identifies which person as most at risk for developing hypertension. Go ahead and read and pause. All right, it's a 52-year-old male who smokes and has a parent with hypertension. Remember, hypertension is more prevalent in men who are under 55. Smoking tobacco is a big risk factor. History of a close blood relative is here. Some of the other risk factors would be things like age, sedentary lifestyle, and stress. All right, so which one of these blood pressures meets the criteria for stage 1 hypertension? It's to select all that apply. And the answer here is C and D, because stage 1 hypertension is when the systolic blood pressure is 140 to 159, or the diastolic is 90 to 99. And in this case, that 182 over 100 meets the criteria for stage 2. And our last question, patient's blood pressure has not responded to the prescribed drugs for hypertension, so which of the following should the nurse assess first? And again, it's adherence to the drug therapy. I wonder if I did that question already or just read it. Okay. All right, guys, that brings us to the end of this lecture on hypertension. Hopefully it helps you out and you understand hypertension a little bit more. Feel free to ask me questions in the comments, or if you're one of my students, go ahead and send me an email and I'll see what I can do to help you or talk to me in class. All right, guys, give me a like and a subscribe. Thank you very much.